Health happens at home with the things that you do every single day. And the only person that can make you healthy, there's no doctor, there's no anything. The only person that can make you healthy is you. And we should see breast cancer like we see any other health challenge. We should see it as an opportunity. This is your opportunity to reclaim your health if you are willing to step up and do that.
All right. Well, it is a pleasure again to have Dr. Jenn Simmons on the podcast today for I think it's the third time we have you on. So welcome.
Thank you. Thank you. Happy to be here.
We had such great podcast episodes that did really, really well. I have those links in the show notes. We talked about the first one, sort of your personal history and experience and breast cancer in general, and then what to do when you're faced with a diagnosis and how to screen for your breasts and how to prevent breast cancer and all that. But today, now that we had these episodes out, I'll get a lot of these questions on how to, if we can take hormone therapy for women who are faced with a breast cancer diagnosis, and if so, what are their options? So let's maybe first start to explain the different types of breast cancers, because I think sometimes people say, well, I have ER positive breast cancer, I can't take hormone therapy, but there's many other things, HER2 and triple negative, and can get all very confusing, especially if somebody has not taken a deep dive yet. So let's talk about the different types of breast cancers that are out there.
Sure. So first, thank you for having me again. I'm so happy to be here. And obviously, this is a topic that's near and dear to my heart. I actually wrote my book, The Smart Woman's Guide to Breast Cancer, so that people could have access to all of this information and be able to make informed decisions about their care before, during, and after a breast cancer diagnosis. Because obviously there are the group of people that we call previvors. They're at very high risk for breast cancer. Either they come from a breast cancer family like mine, or they have a BRCA mutation or one of the mutations that we associate with a very high incidence of breast cancer, which, while we're touching on that topic, I do want to say that BRCA mutations are not new. They've been around forever. And earlier, about 50 years ago, 60 years ago, if you had a BRCA mutation, you had about a 20% chance of developing breast cancer as opposed to 12 in the normal population. Now, it's an 87% chance, and our genes have not changed.
Yeah.
The only thing that has changed is our environment and the environment that your genes are living in. So some people will take that as an assault. Some people will take that as opportunity. And I hope that your listeners hear this and see it as opportunity, because we can create an ideal environment for ourselves. We can create an environment that fosters health and wellness as opposed to promoting illness. But within the pages of my book, I talk all about the pathology, the different types and kinds of breast cancer. But please know that is only describing what we see underneath the microscope. And everyone's reason why is different. And that is the most important thing that anyone needs to take away from their breast cancer diagnosis. So yes, some people are going to have an invasive ductal carcinoma. That means that their particular kind of breast cancer forms ducts. Sometimes it forms mature looking ducts. So that would be a grade 1 cancer. Sometimes it's barely forming ducts, barely recognizable as ducts. We are supposed to normally make ducts in the breast. So the more it resembles normal tissue, the lower the grade, the less a departure it is from normal. So if it's forming recognizable ducts, we call that a grade 1 cancer. If it's forming things that are duct-like structures but barely recognizable, that's a grade 3 cancer. And if it's something in between, we call it grade 2. So that's how we do the grading. How much does it look like normal tissue? So some people have an invasive ductal carcinoma. It means it's forming a ductal pattern. Some people have an invasive lobular carcinoma, and that means that it is lining up in sheets. We call it Indian filing, where the cells are lining up in a one-dimensional pattern. This is why invasive lobular carcinomas are much harder to diagnose, much harder to pick up in its early stages because the way that it grows in sheets rather than in a three-dimensional mass. Ductal carcinomas tend to grow in a three-dimensional mass. So when you feel a lump in your breast, that's almost certainly an invasive ductal carcinoma. Whereas invasive lobular carcinomas, people report things like thickness, a change in the texture of the breast, a change in the size of the breast. Maybe the breast feels fuller than it did before. So when we say it's an invasive ductal carcinoma, it's an invasive lobular carcinoma, we're talking about what the appearance looks like underneath the microscope. It's all breast cancer. And then there are some special types where there's an invasive medullary carcinoma that is a very poorly differentiated, like it just doesn't resemble breast tissue at that point. And then we look at things like receptors. Now, let me tell you, normal breast cells have estrogen receptors on them, have progesterone receptors on them, have HER2 receptor proteins on them. These are all characteristics of normal breast cells. So then we look at the cancers and we say, okay, have they preserved that part of normal? Do they have estrogen receptors on them? Do they have progesterone receptors on them? Do they have HER2 proteins on them? And if they do, we can use that information to sometimes modify treatment.
Mm-hmm. So one question. So if I understood correctly, so we have when you're talking about invasive ductal carcinoma, the ductal or the lobular, these are just the structure. So this is the way it's the cancer or the cancer is lining up or clumping in the breast. So it's kind of a characteristic, but you can have that characteristic plus have if it's receptor positive or negative, right?
Right. So the receptors, we're talking about now what the individual cells look like. So invasive ductal carcinoma, invasive lobular carcinoma, this is the big picture. This is how is this tumor presenting itself? How does it look under the microscope?
And are they always in the ducts of the breast?
No. An invasive cancer, by definition, is not in the ducts of the breast. It is growing outside of the ducts of the breast, because if it's contained within the ducts, we call that DCIS, ductal carcinoma in situ, which is a horrible, horrible misnomer, because when it's contained in the ducts, it is not cancer.
Well, then why do people say it is? I don't understand.
Because then they can treat people. They can put them in a category and put them through the ringer. They can do surgery on them and justify doing surgery and doing radiation and putting them on medications that ruin their lives. This is why. This is the business of medicine.
This is horrifying to hear. So DCIS is not a cancer. It's just, but it is cancer. What's contained within the ducts, and that would never form into something else.
But by definition, when we're talking about cancer, we are describing something that could potentially threaten your life. Otherwise, it's not cancer. Otherwise, it's some kind of non-cancerous growth. So unfortunately, DCIS got named ductal carcinoma in situ.
Yeah.
Had we called it anything else, it would not provoke the kind of fear and anxiety that it provokes. Had we called it anything else, I was speaking to Dr. Thomas Lodi. I don't know if you know Dr. Lodi, but he is a world-renowned cancer doctor. And he's like, well, what if we instead of calling it cancer, what if we picked a different one of the zodiac signs? What if we called it Sagittarius? I said, please don't call it Sagittarius. I'm a Sagittarius. I don't want that on my back. He's like, okay, we'll call it an Aries. Fine. I don't know any Aries. I'm all good with that. And I mean, that's the thing. You gave it this very unfortunate name that is not true. No one dies of DCIS. No one, ever, 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 ever. And only 20% of DCIS, if you did nothing, only 20% of DCIS would go on to become invasive cancer. 80% would do nothing at all.
And you're saying that most doctors who are seeing DCIS, they're not going to wait to see if you're the 20%. They're just going to start treating you, saying we're not going to risk in case you're the
Not
20%, right?
not only are they not going to wait to see if you're the 20%, they tell you that you have cancer and treat you like you have cancer.
Mm.
So outside of chemotherapy, which incidentally, there was a clinical trial about 10 years ago for people who had DCIS to get a couple of doses of chemotherapy. But putting that aside, which thank God that trial has stopped, these women diagnosed with DCIS are getting surgery, which is deforming at best. Sometimes they're getting mastectomy, which you never, ever, ever are the same after mastectomy. Those scars run so deep. And I don't care what you do, you cannot prepare a woman for mastectomy. You just cannot prepare them for the mental devastation that comes along with mastectomy. So these women are having lumpectomies, they're getting mastectomies, they are having radiation, which depending on the side does very permanent damage. And if it's on the left side, we're talking about very permanent damage to the heart, which heart disease is by far and away exponentially the threat to a woman's life. So you're taking a condition that is not even fatal and then giving these women a fatal disease.
Mm-hmm.
I mean, it is insane. And then they're all put on, for those that have hormone positive DCIS, which is almost all of DCIS, because these are cells that have, by and large, preserved their normal anatomy. So it's normal to have estrogen receptors on the breast cell. So these women are all put on hormone blockade and their lives are ruined as a result. And so we are taking a condition that would have never, ever, ever harmed women, and we're harming them. We are really harming them, and we are shortening the duration of their life as a result. So if you're diagnosed with DCIS, even though the DCIS would never kill you, treating the DCIS like it's breast cancer will.
Yeah, we talked about this on our last episode because the DCIS, the 20%, we could say, well, if there are women who say, I'm too afraid to find out if I'm the 20%, but you said through, if I remember correctly, through the proper screening and diagnostics, you can make sure that you're not one of those 20%. It's hard to wait in between, right?
But I'm not saying to sit around and wait. Unfortunately, that's what the conventional medical model does. And they do it for everything. They do it for heart disease. They do it for diabetes. They do it for osteoporosis. They do it for everything. You're not bad enough yet. Wait till you completely fail. And then we're going to put you on a medicine that is going to require another medicine, that's going to require another medicine, that's going to require another medicine. So like, I have plans for you. Here's my way that I'm going to get you on 6, 7, 8, 9 pharmaceuticals. And that's the way the system is designed. And no one's breaking that system. And DCIS is no exception. Yeah. Because once you get people into the system, they require more and more and more support. But what if instead we recognized that these changes existed? We recognize that they have Aries, because I'm not using that other term. And we said, okay, let's figure out what this is in response to. What is going on with you? And let's help you to optimize your health so that you don't become the 20%, because we have this amazing opportunity. And that's what I see DCIS as. It's opportunity. This is your opportunity to take back control of your health. You don't have to continue down this road. Come, there's a beautiful world over here. Come join us. And that's exactly what it should be. That's how we should be responding to these changes. But instead, we use it as a business.
Yeah. Unfortunately, fear has a lot to do with it. And we're scared anytime somebody has the word cancer in them or carcinoma, let's get it out as quickly as possible. I don't want this.
But that's by intention. Let's scare them, because when you're scared, you can't think. This is why I wrote my book. This is why I wrote The Smart Woman's Guide to Breast Cancer, because no one is making informed decisions. No one.
Yeah.
And if you don't have cancer, and DCIS is not cancer. If you don't have cancer, there is no rush to do anything at all. Take a breath, take a pause, learn, educate, understand. And only from a place of knowledge and understanding can you move forward in a meaningful way and make the right decisions for you, because whatever decisions you make around this time in your life are going to affect you for the rest of your life. And it's really important to make the right decision.
Yeah.
Because if you're going to live another 10, 20, 30, 40, 50 years, depending on how old you are when you get this quote unquote diagnosis, that's a really long time to live with a decision that you regret.
Yeah. It
A
sounds like
really long time.
It sounds like almost the DCIS should be called ductal growth, perhaps in situ, in that it's perhaps something that not necessarily cancerous that you can watch and shrink.
Right.
And so I'm wondering then if through your experience, sorry to interrupt, but through your clinical experience, how many women have you been able, who've had a DCIS, have you been able to work with and say, look, now we don't have any more DCIS and you can go and live your life with cancer, quote unquote, cancer free?
Yeah. So there are lots of people around the country who are taking a watch and wait approach with DCIS. Unfortunately, I actually don't think that is the solution either, because I think that we should be using that as an active opportunity. I don't think you should be watching and waiting. I think that you should be doing the things that we know drive health and looking inside and seeing what you have that you don't need, what you need that you don't have, and figure out why you're having these cellular changes. But there are people out there who are not kind of pushing that heavy duty treatment, not treating it immediately like it's breast cancer, but not enough. Now, there is a woman named Donna Pinto. She has the group called DCIS 411. And she shares a lot of information and resources. And she and her group are doing a really great job of supporting women with a DCIS assignment, diagnosis, whatever you want to call it. But I think we should do what the cervical cancer people did, where they stopped calling intraepithelial neoplasia cancer, because they used to call it non-invasive cervical cancer too, until people just responded with such fear around that they changed the name to cervical intraepithelial neoplasia. They stopped calling it cancer because it wasn't. And we need to do the same thing with the breast. But we're fighting industry, and it's big business. We're talking about 100,000 women a year in the US. 100,000 women.
Yeah, you imagine
alone.
Globally, considering this is a global problem. It's the second most, or just cancers in general, come right behind the heart disease in terms of number one killer of men and women, right?
It's heart disease, it's cancer, and then it's medical error.
Yeah. Yeah.
Which is frightening. That's the number 3 cause of death in the US is medical error.
That's scary. I wonder what it is globally. I wonder how, now I'll have to dig up that number, but I want to go back to, so it's just amazing. I love that you framed this in a way that it shows how powerful words are, especially if they're coming from a doctor, right?
Yes.
That cancer word, people, or carcinoma, have this fear. And then of course we follow through with that. But if we could change terminology, that really may have such a big impact on our health and healing. But I also love that you're saying, let's not panic, but let's not sit around and wait for something to happen. You've got to take action. You got to be proactive in driving health in order to shrink that tumor or get to a better place. And this is so vital, so important, because I have seen plenty of people go through cancer diagnosis and they're not doing anything to drive health. They're just sort of sitting around waiting or doing whatever it is their doctor is saying, but without really questioning and without taking control, because I think doctors can only do so much. They know only so much and they can only do so much. And you're the one who has to take responsibility of your health and be your own self advocate. But it's just hard. And I get it, especially if you're in menopause and you're feeling like garbage. And then on top of it, you're asked to do all these things that drive your health. And you may not feel like it, but you got to dig deep and get in this if you want to be better. And like you said, this is an opportunity to be the best version of yourself. So why
Yes.
not?
Yes. And I agree with you. Being healthy is hard. It takes a conscious decision every single day. And is it much easier to not watch what you eat, to sit around and watch TV instead of moving your body, to prioritize sleep and being in nature and not overscheduling and making those difficult decisions to end the relationships that are not working for you and take the trash out and all of that? Yeah, being healthy is a full-time job for sure, but it's so worth it because the life you live when you're healthy is so rich and so full and so joyous and so energizing. And it makes a huge difference, a
Yeah.
huge difference. And when this is the only life you know, it doesn't feel hard anymore. So it only feels hard when it's a departure from what you know. But like anything else, it's a muscle that you build. Like I would say before I got to this place in time, like before I was a patient and when I was just just a surgeon and a mother and a wife and like walking through life, basically, it seemed impossible to be where I am right now, especially when I started off. But now this is just my routine. Now, there are many people who are not ready, willing, able, whatever you want to call it, to take responsibility for their health. They would rather blame the pill for not working. They would rather blame the drug for not working. They just are not ready to take personal responsibility for their health. And that's okay. That's their choice. But this life, you get out of it what you put in.
And
That
like
is for sure true.
like you said, I think in the beginning it may be hard, but once you build those habits and it becomes normal for you, it's not hard anymore. You don't think
No.
anymore. And it takes time, maybe even years, because you become this new person and then you weed out the people who they're just not resonating with you and your lifestyle anymore, but you attract all those people who are very supportive of you and who have similar lifestyle changes. Because what they
Yes.
say is you are the average of the five closest friends you have. So if your five closest friends are just like you or your new version, you don't think about it anymore. It's not hard. It's totally worth it. But again, it just you becomes you. And I encourage people to push through. And I know it may be hard in the beginning, but it gets easier. It gets easier.
For sure. And when you look at my community now as opposed to the community that I was a part of 10 years ago, it looks very different. I am surrounded by people now who are just like me,
Yeah.
right? And so then it becomes not hard at all because they eat like me and they move like me and they think like me and they prioritize like me. And so it becomes very normal. It becomes very easy because everyone understands
Yeah.
and we're all in it for the same thing.
Yeah.
And but you have to be willing to make that change. And that change involves really redoing your environment as you know it.
Let's get back to the receptors because I interrupted you
Mhm.
there. We took a total
Yeah, no, it's
tangent
okay.
because you explained then we have the structure of the breast cancer and the ducts in the ductals and the lobular carcinoma. We have the DCIS, but you said you
Yeah.
started to explain every cell in our body practically has an estrogen receptor and progesterone receptor. And so then you started to explain, I think cancer cells also have receptors and then they sort of
Yeah.
fit into each
Well,
other, right?
that's a version of normal. So if your breast cancer has estrogen and progesterone receptors on it, that means that they haven't made such a departure from normal because we expect them to have estrogen and progesterone receptors on them. And that means that they're still paying attention to the cell signaling. If you have a tumor cell that doesn't have estrogen and progesterone receptors on it, this means this is quite a departure from normal. This cell is no longer listening to the cell signaling. This cell is very rogue. They're off the reservation. And so that cell is harder to treat, right? So that's what we mean. So when we say it's hormone positive, we're talking about estrogen and progesterone. And hormone negative means that it doesn't have that estrogen or progesterone receptor on its surface. And then when we say triple negative, we're also saying that it doesn't have HER2 proteins on its surface. And HER2 positive means that it does. And so we use this information to make treatment decisions. But none of that speaks to why you got breast cancer. So I don't want people to get too hung up in that, because all of that information only dictates how the conventional medical world is going to treat you. And they treat everyone the same. So they put you in silos. If you're hormone positive, you get put in the hormone positive silo. If you're HER2 positive, you get put in the HER2 positive silo. If you're triple negative, you get put in the triple negative silo. Nowhere are they saying to you, what's your diet like? What's your metabolic health like? What's your movement routine? How's your sleep? What kind of toxins have you been exposed to? What kind of toxins are you currently being exposed to? What are your detoxification routines? What is your community like? What is your support like? What are your stressors right now? What kinds of things have happened to you over the last couple of years? What spilled over your apple cart? Never are they asking about any of this. What stress management tools do you have? What do you have to lean on? What do you have to get you through this? And what's your plan for turning this around? Never, never do they talk about any of this. And yet, this is the only thing, I would argue, that's important.
You're right.
Because you can have surgery and remove the cancer, but what is stopping the cancer from coming back unless you intervene in all of these areas that I just talked about? Unless you're asking the question, why did this happen? And uncovering the trauma and uncovering the causes, then what is stopping that cancer from coming back? Nothing. Or worse yet, what is stopping the next manifestation of the chronic inflammation that is building in your body? Because cancer is a manifestation, a physical manifestation of this systemic inflammation. So we need to be thinking about that, right? We need to be thinking about where is the inflammation coming from, and we need to help people to restore their health. And there is nowhere within that conventional medical treatment paradigm that we are individualizing anything. Nothing. There is nothing individual about it. You just get placed in these silos. Nowhere are they asking, where did this cancer come from? What is the message? What is your body trying to tell you? Where is the imbalance? Nowhere. And so that is why when people just choose that conventional medical treatment, not only do they not get healed, not only do they not get cured, but they are worse off afterwards, because every single one of those conventional medical therapies lessens people's health.
Yeah.
So our system really, really needs an overhaul. And beyond that, I don't want people to get caught up in what kind of cancer it is and what these receptors are and all of that, because it doesn't mean anything. The only thing that's meaningful is the knowledge that you have an imbalance in your system that is presenting itself as this tumor. And this is your opportunity to ask, what am I supposed to learn here? And at the end of the day, as we spoke about before, health does not happen in a chemotherapy suite, in an operating room, in a radiation suite, in a doctor's office, in a hospital. Health happens at home with the things that you do every single day. And the only person that can make you healthy, there's no doctor, there's no anything. The only person that can make you healthy is you. And we should see breast cancer like we see any other health challenge. We should see it as an opportunity. This is your opportunity to reclaim your health if you are willing to step up and do that.
Oh, you just said it so well. And it's sometimes I bet a little bit harder. I mean, easier said than done. But like we said before, just so worth it. But I want to go on to hormone therapy. Now, let's assume in your book says the whole guide says everything that we need to be doing to if you have a breast cancer diagnosis or if you're just looking to prevent. And then we also had the other episodes where we talked a lot about that. So we're assuming that you're doing all these other things. Okay. Now,
Yes.
what about when it comes to hormone therapy? Because either a woman is pushed into early menopause through her treatments, or perhaps you're getting treated and you're feeling like garbage, but you need support and you need your hormones to be optimized. And all doctors that I know pretty much have said, oh, you have breast cancer, no hormone therapy. So what is your take and how do you treat your patients?
So that's just ignorance. That is just a complete misunderstanding of biology, of physiology. The truth is that one of the treatments that they use for breast cancer, which is tamoxifen, tamoxifen is a synthetic estrogen. All of this conversation around hormone replacement after breast cancer is based on the pharmaceutical industry's version of what causes breast cancer in order to promote the sales of pharmaceutical drugs. So they created this narrative that estrogen causes breast cancer. And so everyone who has estrogen positive breast cancer should go on hormone blockade. It's just that narrative is only out there to sell pharmaceutical drugs, right?
But go ahead.
Estrogen can't cause breast cancer. It's impossible that estrogen causes breast cancer. It would mean that every woman was put on earth for the purposes of developing breast cancer. If estrogen caused breast cancer, why do we see the abundance of breast cancer in the postmenopausal population when you can barely measure their estrogen? They have so little estrogen, it's barely measurable. If estrogen caused breast cancer, why don't we see it during the times of estrogen surge, puberty, pregnancy? During pregnancy, we have 10 times the amount of circulating estrogen, and yet breast cancer during pregnancy is exceedingly rare, exceedingly rare. So estrogen, of course, does not cause breast cancer. And in fact, drugs like tamoxifen, these are synthetic estrogens, and they sit on the estrogen receptor. But when we look at what the estrogen receptor does, it is actually a brilliant receptor that responds to our different estrogens. It responds one way to estradiol and one way to estriol and one way to estrone. And these are our inherent estrogens. So that narrative about hormones cause breast cancer is solely there for the purposes of selling pharmaceutical drugs. But the truth is that there have been 30 studies on women who have had breast cancer and have taken hormone replacement afterwards. And they all have the exact same conclusion. With the exception of the habit trial, they all come to the conclusion that there is no increase in breast cancer recurrence. And if you have a recurrence, and let's face it, women who take hormones after breast cancer have recurrences, and women who don't take hormones after breast cancer have recurrences. But if you're taking hormones after breast cancer, you have a better outcome, even in the face of a recurrence, than you would if you don't. Now, I don't know if that's selection bias, because the people that take hormones after breast cancer tend to be healthier, tend to be more health conscious, tend to be doing more things than promote health. So it could be selection bias. I don't argue with that. However, we do know that when women go through menopause and are deprived of estrogen and progesterone and testosterone, they undergo significant health decline. They undergo decline in brain function, in heart function, in bone function, in joint function, in sexual function, in mood dysfunction. Like all of these things happen, and they happen at a very accelerated rate. So, of course, these women are not going to feel well, and they're not going to have good outcomes as compared to the women in their cohort who are taking hormones.
Mhm.
The women taking hormones are going to have better brain health, better heart health, better blood vessel health, better bone health, better joint health. And this is going to lead to longevity. Now, I did mention that the IMPACT trial did show an increased risk of breast cancer recurrence in women who had breast cancer and took hormones, but only in a subset, only in one specific subset of women who had breast cancer, were on hormone replacement, and also taking tamoxifen. So, in my opinion, that is because, first of all, you're essentially doubling up on the estrogen if you're taking tamoxifen and hormone replacement. So maybe they're hyperestrogenic. Maybe it's because the liver couldn't detoxify because it was too much estrogen. Maybe it's because tamoxifen itself is carcinogenic. Tamoxifen itself, because it is a synthetic, non-biologic estrogen, maybe it's the tamoxifen itself that caused it. So it is not my practice. I do not have my women who have had breast cancer and are on hormone replacement. I never prescribe tamoxifen along with that. In fact, it is not my practice to prescribe tamoxifen at all because I don't believe in giving non-bioidentical estrogens. I think that those are foreign substances that which are pro-inflammatory. So I don't use them ever.
I have a question. I'm a little confused because doctors, first of all, doctors will argue, the ones who don't want to put their women on hormone therapy, that estrogen is proliferative and it is helping us grow muscle and bones and tissue, which is true. But then they say, well, if it's proliferative, we give them tamoxifen, which you said it's a synthetic estrogen, but I understood it was an estrogen blocker. So you're blocking estrogen with estrogen, or am I just not understanding
Yeah.
something?
Yeah. So you're giving tamoxifen in a ratio that is 10 times higher than the circulating estrogen that you have in your body. So essentially, it's crowding the estrogen out and occupying the receptor.
Oh, wow. Okay.
Yeah. So
That
it's sitting on the same receptor that estrogen is, but you have so much more tamoxifen than you have estrogen that it's basically crowding out the estrogen.
So then, okay, this is why I understood some people say that estrogen, historically, breast cancer was treated with estrogen. But
Yes.
I don't know if was that, but historically, I don't know how far back we're going. We're talking about maybe they were using not high doses, or maybe they weren't using synthetic. I don't know what that meant.
If you're a postmenopausal woman, there's hardly any estrogen around anyway. But if you give estriol, estriol primarily stimulates the beta receptors in the breast, and those are the receptors that are more active in the second part of your menstrual cycle. And those are the receptors that tell the breast tissue to involute. And so that is how we used estrogen for treatment. We used estriol.
Wow. So this is just,
And we could now too. The reason that we don't, you understand, is because you cannot trademark a molecule of nature. So there is no way for the pharmaceutical companies to capitalize on this. If you are going to use bioidentical hormone for treatment, the pharmaceutical companies cannot capitalize on it. So they have to change something to make it non-bioidentical. That's what tamoxifen is. Tamoxifen is a non-bioidentical estrogen. And
this
they're
again.
just hoodwinking the public. That's all that's happening. They are hoodwinking the public.
So why don't doctors say if estrogen is, so the way I explain it, estrogen is proliferative, but we also have progesterone to balance things out, right? When we have an
Mhm.
endometrial lining that's getting full, then we have progesterone to bring it back down. So why wouldn't somebody treat
But
women?
let's be careful. Not all estrogen is proliferative. Some estrogens are non-proliferative. They're the opposite. So we have this beautiful symphonic balance of hormones in our body created by God. And it's only when we get out of balance that we begin to have problems. And the most demonstrative of that is when a woman goes through menopause and loses that beautiful symphony of hormones. And that is when we really start to rapidly decline. But think about it, thousands of years ago, because we are modern beings living on a very old gene code, people would die of an infection way before menopause. They would get eaten by a saber-toothed tiger well before menopause. We didn't live that long. But
Mhm.
now we have antibiotics and orthopedic surgeons. So you don't die of a fracture anymore, hopefully. And modern life allows us to live far beyond when our ovaries can support us.
Mhm.
But we have this magical opportunity to replace the ovarian hormones. And we need to start doing that universally. So, not all estrogens are proliferative. But yes, I agree with you. Progesterone is the answer to the proliferation. Progesterone is our calming hormone. And progesterone has also been used for treatment of breast cancer, as is testosterone.
Mhm. Interesting. So then, okay, this is so crazy because I hear also some people say, well, bioidentical hormones too is pharmaceuticals. You have to go to the pharmacy to get it. And this is you can have the argument any way you want. But in the end, I think most people who are listening now are quite understanding and convinced of bioidentical hormones being exactly the same structure as your own.
Yes, yes. The chemical structure is the same. It's all synthetic,
Yeah.
right? I'm not saying it's not synthetic. It's all synthetic. But we're talking about is the chemical structure the same as our endogenous hormone? And the answer to that when we're talking about the bioidenticals is yes. So when we're talking about the these altered estrogens, the problem with them is when we consume them in our body, they are not recognized by our cells in the same way. So anything that is foreign to us is going to cause some degree of inflammation. Sometimes it causes a little inflammation. Sometimes it causes a lot of inflammation. So that depends on the host.
Mm-hmm.
So each host is going to respond differently. Even in the Denmark birth control pill study, 1.8 million women, not all of them got breast cancer. However, we did see an absolute link between consumption of birth control pills and breast cancer. Undeniable. And the longer you're on them, the higher your risk of getting breast cancer. It's not because your body is not accustomed to having estrogen and progesterone in it. It is, right? Your body's not accustomed to that non-bioidentical version
Mm-hmm.
of estrogens and progestins.
Mm-hmm.
And so there are some people who are just not going to tolerate that, and they're going to manifest a cancer because that is going to be the presentation of their inflammation.
So then let's talk about the hormone treatment that's available, because I'm just doctors who don't treat. I mean, even actually the Institute of Bioidentical Medicine, I went through their program and we learned that actually with the training that we got, has nothing to do with breast cancer, treating a woman through menopause if she has breast cancer, but it was more the message that I got from that is wait until she's got her treatment or she's finished and then put her on hormones, because we, just like you said, we know that women who are on hormone therapy, they have a better chance of survival post cancer than the woman who isn't on it. So I want to understand a bit more how doctor like you who is working with women, and you are training other doctors, or you're planning on training other doctors, right? Which is going to be
I am.
amazing. How to treat a woman through menopause if she is going through, she's just been diagnosed and going through. I want to know how. First of all, the option is, I understood from you, yes, she can go on hormone therapy, the right one in the right time. And I gathered from you from the last conversation we had that you also said you would only give hormone treatment if she's doing all the other things that are supportive of health,
Yes,
right?
yes, yes. Because, first of all, I have two initials after my name and I want to keep them. And I want to do this in a responsible way. And I also inherently believe that we have to take responsibility for our health. So if I'm working with someone who's not willing to take responsibility for their health, who is looking to me to be their savior, I can't be anyone's savior. The only person I can save is me, right? You have to save you. And I will only work with people who are willing to and wanting to take responsibility for their health. And that means working together to figure out your why, looking at all the reasons why people get breast cancer. And the list is long. And so we're looking through that list to see, do you have oral infections? Have you had a mold exposure, a Lyme exposure? Do you have chronic virus exposure? Are you in a difficult relationship that you need to get out of? Are you in a bad job that you need to get out of? Like, what is driving this disease? Because we have to work through that. I'm not just putting someone on hormone replacement if they're eating the standard American diet, if they're not exercising because they're working 12 hours every day, if they are not sleeping at night because they think that that's the best time to get work done. I'm not prescribing hormones for that person because that person has a lot of things to work on first. And I want to be clear, hormones are not some miracle solution. They are something wonderful added to an already great lifestyle routine, right? But they're not going to save someone who's not doing the rest of the things. And if someone comes back to me and they're like, yeah, I tried and it's not doing anything for me, what else is going on for you? Because again, they're not a miracle. They're a beautiful addition to an otherwise great routine, right?
Absolutely.
Now there are some instances like what Dr. Rosensweet teaches, which is what I truly, truly believe. We are not giving women hormones so that we can restore fertility, restore menstruation. This is not our goal. Our goal is to keep women out of wheelchairs, nursing homes, and adult diapers. So we are not giving huge whopping doses of hormones. We are monitoring your hormone levels. And we are giving enough to maintain and promote bone health, brain health, heart health, sexual health, cognitive health. This is our goal. This is our goal. And in doing that, there are other things that you need to do to support those goals. I can't get you there if you don't have metabolic health because your diet is carbohydrate rich. I had a woman last week who said, I can't not eat dairy. I have to eat cheese. Okay, if you have to eat cheese, I can't help you. You're not open to really being healthy. She's 60 pounds overweight. You have to make a decision. Do you want your health or not? And if you want your health, you have to be willing to say, okay, I'm gonna give up cheese. So I'm only working with the person that really wants to capture their health. Because if you're not going to take enough responsibility for your health, then I'm not going to assume that responsibility. And for me right now, the prevailing thought is that hormones are not safe after breast cancer. So I'm absolutely going to prove that they are, but I'm going to pick my candidates very carefully. And the other people around me that are going to be trained by me, that are going to do this, I want them to pick their candidates carefully too. Because if we're going to prove that this is safe, we have to pick the right people to prove it in.
So how does a woman who's listening now, and she just got her diagnosis, and breast cancer, and she wants to go on hormone. She hears this episode and says, okay, I really got it. I want to feel better. Because sometimes I have women who are trying their best, but because they're not sleeping well, they have the hot flashes. Like, it's really hard to get to the gym. And then when you don't get to the gym, then, so I like to use this hand in hand, because when you support good sleep and managing their stress through some hormones and getting the progesterone in, then it's much easier to tackle these things.
I agree with you. I agree with you. But the person that can't get there, but wants to get there, is a totally different person than the person that says, I can't unless you give me this.
Yeah.
So it does take a little bit of ability to determine who that person is, to when you give her a little bit of hormones and get her started and she feels better, she's motivated to do these other things for sure. So I'm not saying that you have to be all the way there before I start you on hormones. I'm saying you have to be the right person and you have to be willing.
Absolutely. So if she's listening here and she wants to go on the hormones and she has a doctor who's resistant and says, no, estrogen is proliferative, or you have estrogen receptor positive cancer, and we don't want it to grow. And what can she say, or what tools can she have with her to be able to get to where she needs to be? Because she says, I'm doing the work and I really want to get on.
Right. So that doctor is never going to say yes, but most doctors are completely hormone illiterate. And I'm including the GYNs in that population. The vast majority of GYNs are completely hormone illiterate. They came up through the WHI era, because the doctors that existed before the WHI era are few and far between at this point. The ones that knew the heyday of hormones. And even if they existed, they changed their tune during WHI and haven't gone back. And there is no hormone training in residency, none. So these doctors are not learning in their training. And the only ones that are becoming hormone literate are the ones that are actively pursuing it after training. And most doctors are so busy in their lives. Try getting an appointment with an OBGYN. You'll wait 6 months. So these doctors are so busy, they're not really gung-ho on going to learn more outside of their normal practice. And it's not like anyone's paying for them to do that. They have to go out of pocket to get trained to do hormones. So it takes a very, very highly motivated and astute person to go pursue this information. So hormone literate physicians and providers are few and far between. And the one that says to you, you can't go on hormones because they cause breast cancer, or you had breast cancer, or you had hormone positive breast cancer. Incidentally, they don't even go that far. Like they tell women who had hormone negative breast cancer that they can't go on hormones afterwards. So even logic isn't there. They're just lost in a narrative, right? So that person is never going to say yes to you. So your decision is you either go find a different doctor, or you just don't tell them, don't have the conversation with them. I think the time now is, and I'm not saying that you have to take on this responsibility, but the patient is the doctor of the future. No one is ever going to know you better than you know yourself. And you know what's right for you. You know what's right for you. The women that come to me and want hormones, they are very driven by that thought process and that decision. They've made that decision. So if I'm not going to give them hormones, they're going to find someone who will. Like, their mind is set. And all of their doctors have told them up until now that they can't have them. And they are on a mission to find someone to say yes. So I don't think anyone should be listening to that doctor who says you can't have hormones after breast cancer. That's just their ignorance speaking, but it's simply not true. Now, do I think that everyone should just be given a blank prescription? No, I think we need to be selective. So if you get a breast cancer diagnosis, I'm not starting you on hormones the next day because there's work to do. We need to figure out why you got breast cancer. Some people need some elements of breast cancer treatment. If you have a big disease burden, the horse is out of the barn. Like, we need to do something, and we need to do something quickly to turn your ship around.
Mm-hmm.
So some people need conventional treatment, but at the same time, we need to be looking where did this diagnosis come from? What is driving it? What is causing it? Where do we need to focus on to restore balance and homeostasis? How did you get into this stress chemistry? And how do we get you into the chemistry of joy that fosters health? And then, yes, we're going to give hormones to enhance your health because that's what it needs. Many people can't recapture their metabolic health without hormones. And I get it, right? But let's look at how can we optimize while giving you hormones, because that's really what it's about.
Mm-hmm.
And so I tell everyone, start by reading my book because all of the elements are there. The Smart Woman's Guide to Breast Cancer, all of the elements are there. And then find someone to work with. If it's not me, find someone to work with who is very knowledgeable in this space. And along with Dr. Lindsay Bergson, like, we're going to train a lot of providers this year and years to come, because we want to make sure that there are both hormone literate providers and providers who are comfortable with and willing to treat women with a history of breast cancer, because these are people too, and they deserve the same opportunity for health that everyone else does. And we have completely abandoned these women, and it's wrong. These women who have been diagnosed with and treated for breast cancer are told that they should be grateful to be alive. And believe me, they are grateful, but it is very hard to feel grateful when you can't think, you can't remember words, you can't sleep, you're anxious, you're depressed, you have bone aches, joint aches, you've gained weight, your fat has redistributed, you don't recognize your body, your clothes don't fit, your hair is dry, your skin is dry, everything's dry. You have no libido, sex is unwanted and painful, your relationship is suffering, if you have a relationship at all. It is very hard to feel grateful when all of this is happening. And yet, this is how we leave most women after breast cancer. And I am changing that. I am forever changing that, because this forgotten woman, this is the title of my next book. This forgotten woman is now remembered.
So well said. I'm so grateful that you're here and people can reach out to you. I'll have your link to in the show notes, how to find you. And it's hard enough to find a doctor to treat a woman through menopause, but when you've got breast cancer, really, it's doubly, triply, quadruply hard.
It is. I'm changing that.
You are changing that. So I'm excited. I want to get a list of those doctors you've trained once you're ready. And one last thing, a question that's been on my mind is when we started talking about tamoxifen. So a woman who is now post, or at least treatment, and she's given the tamoxifen oftentimes, you're saying this is actually synthetic estrogen, very high levels to block the receptors of the estrogen, so that it's an estrogen blocker. Can she, instead of the tamoxifen, just take bioidentical estrogen at a certain dose, or how does that space get?
So most women who are given tamoxifen because they're premenopausal, right? So their ovaries are still producing, and it's not their ovaries that cause the breast cancer. So those are women who I actually don't recommend they go on tamoxifen, but let's look at what's happening. Are your detoxification pathways working the way that they're supposed to be working? Do you need support there? And do you have a progesterone deficiency? Maybe that's what's happening and you need more progesterone. So that is a woman that I'm looking at all of the reasons why people get breast cancer and helping them to restore balance and maybe providing them with some progesterone as opposed to putting in more estrogen, because that is not the solution for anyone.
Got it. Okay. Oh, you've given us so many solutions. And you know what, Dr. Jenn, I think I have like 10 other questions that I never got to, but we will just have to have another recording. But you've already broken that stigma or that misinformation that women who are diagnosed with breast cancer cannot take hormone therapy. It is absolutely not true. And it has to
Not
be
true.
done in the right way. So thank you so much for coming on and clearing some of this confusion. I absolutely love what you're doing. Keep going. I am there like rooting behind you and sharing as much information about you as I possibly can. So thank you. And
Well, thank you so much. Thank you for having me. I really appreciate it.
I can't wait to have you on again. Bye bye.